Okay, so we'll discuss inshallah the next, the second guideline. It's a green top guideline about the management of third and fourth degree perineal tear.
Sorry, Dr. Al-Fatih, no voice.
Okay, sorry. So now we'll discuss about the management of third and fourth degree perineal tear. The overall incidence in the UK is about 2.9%. It's ranging from 0 to 8%, with the incidence of, in case of private party, is 6.1, and in case of multi-bar is 1.7. So it's so high in case of primary parts ladies more than multiparous ladies. So this is the recall question asked about the incidence of third and fourth degree perineal tear in case of primus and in case of multiparous. So in primus ladies is about 6.1 incidence and 1.7% in multiparous ladies. So overall this is 2.9. And here is different between the parous lady and the multiparous and the private parous ladies. So this chart shows the classification of perineal tear. How the important question, how should the obstetric and anal sphincter injuries can be classified? So how to classify the perineal tear? This chart shows the classification of perineal tear. We have 4 degrees. Here, first degree perineal tear, and second and third degree perineal tear, and fourth degree perineal tear. So what is the difference between these 4 types of perineal tear? The first degree, it means there is injury of skin or vaginal epithelium only. This is the only injuries for the skin, and maybe skin laceration or injury of vaginal epithelium. Second degree perineal tear, it is involved injury of the fascia and muscle of the perineum. So, and not include the anal sphincter. So here, this is the difference between second degree and third degree. Third degree, it involves the muscle of the and fascia of the perineum and involve the anal sphincter complex. So if involves the muscle and fascia of the perineum and not involve the anal sphincter complex, this is the second degree perineal tear, and third degree perineal tear if involve anal sphincter injury. And we have subgroup for third degree perineal tear, 3A, 3B, and 3C. So in case of 3A, there is involved about 50% of external anal sphincter thickness torn. So if involved about less than 50% of external anal sphincter, this is the 3A. So this is the type 3 in case of third degree perineal tear. If more than involve more than 4% of external anal sphincter thickness torn, this is the 3B. And 3C if involve both external and internal anal sphincter torn. So here, this very important to differentiate between 3 subgroup of third degree perineal, because this is a recall question. Here, I remember this question about the case of third degree perineal tear and involve about 50% of external anal sphincter. So here, according to the classification, is If less than 50, it is 3A. And more than 50 is more than 50, this is 3B. So in the question, ask about just 50. So here, according to the guideline. Hello? Hello? So if you give percentage as 50% of external asphycter, and there is doubt about the decision of this, is it 3A or 3B, according to the guideline, you should choose the highest degree rather than the lower degree. So in the question, the answer will be 3B. If you give about 50% of the external asphycter, so here will be 3B. Okay? This is a recall question. And 4-degree perineal tear involves the perineal fascia and muscles, and also both external and internal asphycters and the anal mucosa. So this is about the classification of perineal tear. So first degree and second degree, third degree and fourth degree. Is it clear? Any question in this chart? So this picture show here the 4-degree of perineal tear. Here the first, only skin laceration, and the second is involve the perineal muscle, and the third here involves the perineal muscle and internal sphincters. Here for all the perineal muscle and also sphincter and sphincter complex and rectal mucosa. This is about. So anybody knows about the rectal bottom hole bar? Anybody knows? What is the difference between 4-degree perineal tear and the rectal buttonhole bar?
Yes.
Yes, any difference?
Yes. الريكتال بوتون هول هو involvement للريكتال ميوكوزا without involvement للانال sphincter.
Yes, so it is the anal sphincter is intact.
Intact.
So not be classified as the 4th-degree perineal tear. Okay, thank you. So you should be repaired also and may lead complicated by rectovaginal fistula. But if you give you scenario and about the rectal buttonhole bar and there is no involve the external anal sphincter, this is diagnosed as the buttonhole bar and should be repaired and not managed as the 4th perineal tear. So what about the risk factor of the case of anal sphincters? So the following are the risk factor. First start with Asian ethnicity and nulliparity women, birth weight greater than 4 kilogram, shoulder dystocia, also the risk factor, occipito posterior position, prolonged second stage of labor, instrumental delivery. So in case of prolonged second stage of labor, it depends on the duration of the second stage, if between 2 to 3 hours or 3 hours to 4 hours or more than 4 hours. So the risk is increased according to the duration of second stage. And in case of instrumental delivery, also the risk is increased according to either use venous delivery or forceps. If you use venous delivery is without episiotomy, or you do episiotomy, and if you do forceps delivery without episiotomy or with episiotomy. So the risk for by the instrumental delivery, it depends on the type of instrumental delivery, either venous or forceps delivery. So the risk factor for sustaining recurrent oocysts in subsequent pregnancy include Asian ethnicity, forceps delivery, and birth weight more than 4. This is the most important risk factors for oocysts. So obstetric asphyxial injury can be prevented. This is an important question. Can you prevent obstetric asphyxial injuries? So explain to women that the evidence for the protective effect of episiotomy is conflicting. So mediolateral episiotomy should be considered in instrumental delivery. So in case of instrumental delivery, you should do mediolateral episiotomy. And where episiotomy is indicated, the mediolateral technique is recommended with careful attention to ensure that the angle is 60% degree away from the midline when the perineum is distended. So if you do mediolateral episiotomy, an angle should be about 60 degree away from the midline. The perineal protection at crowning can be protective, and warm compression during the second stage of labor reduce the risk of disease. So here, the most important one is about the warm compression during second stage. So there's evidence based to support the warm compression during second stage, and it is more effective measurement to prevent an asphyxial injury. So identification of obstetric and asphyxial injuries. How can count the identification of the obstetric and asphyxial injuries be improved? NICE recommended before assessing for genital trauma, healthcare professionals should explain to the woman that they plan to do and why over inhalational analgesia, and ensure good lighting and position of the mother so that she is comfortable and so that its general structure can be seen clearly. The examination, systemic examination, should be performed gently and may be done in immediate period following pairs. In genital trauma is identified following pairs, further systemic assessment should be carried out, including rectal examination. So this is about the management of obstetric and asphyxial. So first with explain by counsel the mother and over inhalational analgesia, ensure there is good lighting and position of the mother, and do systemic examination. And if there is genital trauma identified following birth, further systemic assessment should be carried out, including rectal examination. So what about the perineal protection? Anybody knows about the perineal protection?
There is two technique, I think, so hands-off technique and
Yes.
hands-on technique.
Yes.
So it doesn't give like there is no much difference between these two techniques. But I think in one of the place I read, I think hands-on technique is better one. I don't know, like there's a question also, but it is confusing. Yeah.
Yes, and this perineal protection also include the left hand slowing down the delivery of the head, and right hand to protect the perineum and cancel the mother, don't push, and consider the episiotomy. This is about the perineal protection. So figure of 8 structure should be avoided during the repair of oocysts because they are hemostatic in nature and maybe cause tissue ischemia. So avoid to do figure of 8. A rectal examination should be performed after the repair to ensure that suture have not been inadvertently inserted through the rectal mucosa. If a suture is identified, it should be removed. So what is the technique should be used to repair of rectal mucosa? This is very important. And a lot of question came in exam, recall question asking about the technique and the suture used for the rectal mucosa and for repair of external allen on internal allen sphincter. So you should memorize this. So in case of rectal mucosa, should be repaired with suture using either continuous or interrupted technique. So in case of rectal mucosa, use continuous or interrupted technique. And suture you can use polygylactin suture. So use polygylactin suture, and you could use continuous and interrupted. This is about for rectal mucosa. So if you want to repair rectal mucosa, you can use suture technique, continuous or interrupted technique, and use polygylactin suture 3-0. And figure of 8 should be avoided. And regarding the external allen sphincter repair, for repair of full thickness allen sphincter tear, either overlapping or end-to-end technique. So here, overlapping or end-to-end technique. So end-to-end technique, this means by approximation. Methods can be used with equivalent outcome. So you can do overlapping or end-to-end technique. This is in case of external allen sphincter. If this full thickness, for partial thickness, you can use end-to-end technique. So if you have question and ask about the external sphincter, you choose first end-to-end technique, because end-to-end technique can use in full thickness and partial thickness tear. So for external sphincter, can use end-to-end technique. In case of full thickness, you can use overlapping technique, and for partial thickness, use end-to-end technique. So what is the suture material? 3-0 polygylactins should be used to repair rectal mucosa, and it may cause less irritation and discomfort than polydoxynon's BDS suture. And when repair of external allen sphincters or internal allen sphincters, muscle is being performed, either monofilament suture such as 3-0 BDS or modern braided suture such as 2-0 polygylactin can be used with equivalent outcome. So, and rectal we said before, it is 3-0 polygylactins, and for the external allen sphincter or allen sphincters, internal allen sphincter can use 3-0 BDS or 2-0 polygylactin. So you can use polygylactin in both for rectal, but it's 3-0, and for internal and external allen sphincter 2-0, and you can use also 3-0 BDS for external and allen sphincter. Here, this chart shows the suture technique for rectal and for external allen sphincter and for internal allen sphincters, and what is suture use. For allen sphincter, we use continuous or interrupted and 3-0 polygylactin, and here is end-to-end, because we said before, end-to-end can use in the partial and full thickness. In case of full thickness, also you can complete overlapping. So you choose end-to-end technique for external sphincter. Here you can use 3-0 BDS or 2-0 Vicryl. And internal sphincter either interrupted or matrix. Here use 3-0 BDS or 2-0 Vicryl. This is very important slide because a lot of question in exam asking about the technique and the preferred suture. So you should memorize this because a lot of question came in exam asking about suture technique and suture type. Also here, this is show what is about the preferred technique for anorectal, external sphincter, and internal anal sphincter. So, and the suture preferred. This video show how to manage of perineal pair. I posted it already in group. Yes, post-operative management. Yeah, in case of perineal tear, use of broad-spectrum antibiotics is recommended following repair of CS to reduce the risk of postpartum infection and wound dehiscence. And the use of post-operative laxative is recommended to reduce the risk of wound dehiscence. So bulking agent should be not given routinely with laxative, and local protocol should be implemented regarding the use of antibiotic laxative examination and follow-up of women with obstetric anal sphincter repair. This is about post-operative management. Women should be advised that physiotherapy following repair of OSIS could be beneficial. Women who are undergone obstetric anal sphincter repair should be reviewed at convenient times, usually 6 to 12 weeks postpartum. This is the recall question. Where possible, review should be clinician with special interest in OSIS. If a woman is experiencing incontinence or pain at follow-up, referral to specialist gynecologist or colorectal surgeon should be considered. What about the prognosis? Women should be advised that 60 to 8% of women are asymptomatic 12 months following delivery and external sphincter repair. So 60 to 80% of women be asymptomatic 12 months following delivery and external sphincter repair. In the future deliveries, all women who sustained OSIS in previous pregnancy should be counseling about the mode of delivery, and this should be clearly documented in the notes. And the role of prophylactic episiotomy in subsequent pregnancy is not known, and therefore episiotomy should be only performed if clinically indicated. It's not routine. All women who have sustained OSIS in previous pregnancy and who are asymptomatic or who have normal endoanal ultrasonography or manometries should be counseled regarding the option for elective cesarean section. So if the patient is asymptomatic and have abnormal endoanal ultrasound and there is manometries should be counseled about the elective cesarean section to avoid the risk of fistula. This is about the management of third and fourth degree perineal tear. The most important here is the table about the suture technique and suture type, preferred suture type. So in case of anorectal mucosa, you should use continuous or interrupted technique and use 3-0 polyglyctines. And in case of external sphincter, use end-to-end technique and use 3-0 BDS or 2-0 Vicryl or polyglyctines. And internal sphincter can use interrupted technique or matrix technique, and also use the same external sphincter. You can use 3-0 BDS or 2-0 Vicryl. This is all about the management of third and fourth degree perineal tear. So the question 1. Anyone who will share?
Yes.
Dr. Imtinan?
Yes,
Okay.
doctor.
Yes.
A monofilament used to repair the external anal sphincter. It is a 3-0 BDS.
Okay, here option
Yeah.
external anal sphincter. You have
Yes,
3-0
3-0 BDS D.
Vicryl. Here
Yeah, monofilament is 3-0 BDS.
3-0 BDS. Yes, excellent.
Yes,
So it
D.
is D. Excellent.
Yes.
So next. And the bearing of anorectal mucosa.
Anorectal mucosa 3-0 polyglyctan or Vicryl.
Yes.
3-0
So
also.
Vicryl,
Yes.
3-0 polyglyctin is Vicryl is for repairing anorectal.
Yes.
So here the answer
Yes.
is 3I.
3-0 yes, I. 3-0
Yes.
polyglyctan.
Yes. طيب, what about the 3?
A modern braided element used to repair the internal anal sphincter is the 2-0 polyglyctan.
It's the same
Vicryl.
like external anal sphincter. So you can use 3-0
Yes,
BDS or 2-0 Vicryl.
2-0. Yes,
Yes,
Vicryl.
it is.
Polyglyctan H.
Okay, thank you. So can I read explanation, please?
Okay, 3-0 BDS, either monofilament 3-0 BDS or modern braided example 2-0 polyglyctan can be used to repair the internal sphincter. 3-0 polyglyctan also suggests 3-0 polyglyctan to use repair of anorectal mucosa. Either monofilament 3-0 BDS or modern braided 2-0 polyglyctan can be used to repair the anal sphincter.
Yes. Okay.
Okay.
Sorry.
Thanks.
Okay. The last question, I think.
I will continue.
Yes, Victor.
Hello, Dr. Dalia. Okay. Thank you, Dr.
Yes.
Imtinan. Thank you so much. Dr. Dalia.
A 30-year-old woman who has just had a normal vaginal delivery at term sustains a perineal tear that involves 50% of the external anal sphincter. You are called to suture this tear. How will you classify the degree of this tear? I will upgrade because it is only 50%. So this is 3B.
Yeah. 3B. Yes, you are
Yes.
right. If there's any doubt to differentiate between 3A and 3B, you choose the highest one. Okay. So this is very important here. Is 50. It is should choose 3B because more than 50%. So what is the answer here? Is wrong because this is wrong answer because according to the guideline, if this is the recall question, okay, so if involved about 50%, you should choose the highest rate. Agree with me? Hello?
Yes, agree. Yes.
The answer, the correct answer here is the D, 3C degree. 3B. Okay? Yeah. The answer here is 3B. Okay? You remember the chart? Hello? So here, the correct answer here is C, not B. Okay?
Yes.
So any question? Okay, thank you so much. Okay.